Welcome to the online lecture series for a Certificate of Proficiency on Advanced Cardiac Life Support, designed by the Council on Cardiopulmonary Resuscitation of the Philippine Heart Association. This is intended for the Filipino physicians, nurses, and other paramedical professionals. You will start your training with recognition of ACLS rhythms. I will be focusing on relevant ECGs in the emergency setting. Knowing how to identify deadly rhythms is of paramount importance in advanced cardiac life support, because the right management stems from identifying the rhythms right. At the end of this module, you are expected to be able to correctly identify a normal ECG tracing and to correctly identify arrhythmias in the emergency setting. In this module, we will brush on your knowledge on anatomy and physiology of cardiac conduction. We will go through basic measurements, intervals, and interpretation of a normal ECG. We will also briefly discuss common mechanisms of arrhythmia and identify ACLS rhythms such as arrest rhythms as well as slow and fast rhythms. Now let's brush on your knowledge in basic cardiac anatomy and physiology. The normal beating heart is shown on the left part of the screen. On the right, we identify the four chambers of the heart: the right atrium, the right ventricle, the left atrium, and the left ventricle. These chambers contract and pump blood as a consequence of getting stimulated or depolarized by the heart's electrical conduction system, as you will see next. The impulses that originate from the sinoatrial or SA node travel through the internodal connections to the atrioventricular node. From the AV node, these impulses travel through the bundle of His and further down the bundle branches. Both the bundle branches terminate in the Purkinje fibers, projecting throughout the rest of the myocardium. The SA node normally generates the action potential, the electrical impulse that ultimately results in cardiac contraction. It is the natural pacemaker of the heart and fires normally 60 to 100 times a minute at rest. In the right atrium, the electrical impulses travel through the internodal connections to the atrioventricular septum towards the AV node. The AV node in turn sends the signals to the His-Purkinje system. On its own, the AV node fires at a rate of 40 to 60 a minute at rest. That is, if the AV node fails to receive impulses from the SA node. The bundle of His is supraventricular in location, and this is where the conduction of impulses through the ventricles begin. It conducts electrical signals further down the bundle branches. When these impulses reach the left and right bundle branches and down the Purkinje fibers, depolarization of the ventricles begin, resulting in ventricular contraction. On their own, if these do not receive any impulses from the bundle of His, the bundle branches and Purkinje fibers fire at a rate of 20 to 40 a minute, a very low heart rate that may not be compatible with life. Now let's transpose these electrical events on the ECG. Remember that the cardiac cycle is normally stimulated with an impulse that starts at the SA node. When this impulse gets to depolarize both the right and left atria, the P wave is produced on the surface ECG. When this stimulates and depolarizes the atria, atrial contraction occurs subsequently. When this impulse travels through the AV node, the electrocardiogram records this as the initial and longer portion of the PR interval. And when the impulse travels further into the bundle of His, the ECG shows the rest of the PR interval. Conduction time through the AV node accounts for most of the duration of the PR interval. A small portion of the last part of the PR interval is represented by the conduction time to the bundle of His. And when the impulse travels further into the bundle of His and its two branches, the ECG shows the rest of the PR interval. Conduction through the Purkinje system is represented by the Q wave. When the impulse spreads throughout and depolarizes the myocardium, that would eventually lead to the contraction of the ventricles, the QRS complex appears on the ECG. Repolarization of the ventricles generates a T wave, which takes place slowly, the reason why it generates a wide T wave. The following shows us a normal PQRST sequence on the ECG at a standard paper speed of 25 millimeters per second. Each small box represents 0.04 seconds, and 5 small boxes sum up to 0.2 seconds. That's equivalent to 1 big box. 5 big boxes therefore would sum up to 1 second. Vertically, 2 big boxes or 10 small boxes are equivalent to 1 millivolt. That makes 1 small box equivalent to 0.1 millivolt. The approach to ECG interpretation in the ER includes a systematic approach. First, you need to check for regularity. Second, check the rate, whether it is fast or slow. Third, check if the rhythm is sinus or not by looking for normal-looking P waves that should be always followed by a normal-looking QRS complex and a T wave. Then you can assess basic intervals and measurements like PR interval and QRS duration, after which determine if there are rhythm abnormalities on the tracing. Regularity is defined by measuring the R-to-R intervals and the P-to-P intervals. These intervals should be the same all throughout the strip for a rhythm to be considered regular. Rate, on the other hand, is determined by following these rules. If the rhythm is regular, you count the number of small boxes in between 2 consecutive QRS complexes and use it as a divisor to divide 1,500, which is a constant number. The number or quotient you get is the heart rate captured on the ECG. Another method is to count the number of big boxes and use it to divide the number 300, which is also a constant if you opt to use this big boxes method. You may also get a heart rate by multiplying the number of QRS complexes contained in a 10-second strip by 6. Or you can use a 6-second strip, count the number of QRS complexes, and multiply by 10. The number or product you get by multiplying these numbers in both techniques is the heart rate. Remember that these methods only apply to regular rhythm ECGs. For rhythms that are irregular, get a 6-second strip, count the number of QRS complexes in a 6-second strip which spans 30 big boxes, multiply the number of QRS complexes by 10, and you have the heart rate. Now let's try to know if a P wave is generated from the sinus node. You have to look closely at the P waves on a strip or monitor. P waves have a smooth contour and are upright in leads 1, 2, and AVF. The P wave is upright or positive in these leads because it follows the cardiac vector and is upright in the leads in the direction of the arrow. If the P wave is always followed by a QRS and T, you can say the rhythm is sinus. Next, we talk about basic ECG intervals. The PR interval is measured from the beginning of the P wave to the start of the QRS complex. It is normally between 0.12 to 0.2 seconds. The ST segment in a normal ECG is the flat segment that begins from the end of the S wave to the beginning of the T wave. This segment is important in the evaluation of possible ischemia or myocardial infarction. The QT interval begins from the start of the QRS to the end of the T wave. This interval may vary between males and females and is influenced by heart rate. It may become shorter during tachycardia and longer during bradycardia. The QRS duration is normally less than 0.12 seconds. Measuring its duration identifies a QRS complex as narrow or wide. It is very important to identify a narrow or wide QRS, more so in arrhythmias, because management is very different for both. What you see on the screen exemplifies a normal sinus rhythm. Impulses are initiated in the SA node. You see a normal-looking P wave, followed consistently by a QRS complex and a T wave, and the sequence occurs in a regular pattern. There are many reasons why one develops abnormal rhythms. One of the most commonly seen arrhythmias is supraventricular tachycardia, or SVT, that is triggered in the AV node. The AV node on the right is enlarged to show a circular re-entry mechanism with near simultaneous activation of the atrium and the ventricles. This creates the ECG tracing as seen below. There are, however, other mechanisms in electrophysiology, but this will not be discussed in this module. In an emergency setting, like when you are delivering advanced cardiac life support, rhythms are generally categorized as slow rhythms, fast rhythms, or pulses or arrest rhythms. Do not easily get intimidated with ECGs. Arrhythmia is easy to learn. One basic concept to remember that will make it easy for you is recognize whether a rhythm is fast or slow. Tachycardia refers to a fast heartbeat with heart rates greater than 100 beats per minute, and bradycardia refers to slow heart rates of less than 60. We begin with the deadliest of them all, the arrest rhythms. Ventricular fibrillation is the most serious cardiac rhythm disturbance that causes ventricles to quiver or fibrillate. It has the chaotic, irregular deflections of varying amplitudes with no identifiable P waves nor QRS complexes or T waves, and the rate is indeterminate. Ventricular fibrillation may appear coarse or fine, as you can see on the screen. Pulseless ventricular tachycardia is a wide, complex, fast rhythm that does not produce a pulse, as the name implies. This rhythm is considered an arrest rhythm since the heart does not practically contract and pump in spite presence of electrical activities that can be seen in the monitor. Asystole, on the other hand, is defined as the absence of electrical activity. It appears as a near straight line on the cardiac monitor. Pulseless electrical activity practically means a state of cardiac arrest. There might be electrical activity on the monitor, but the heart does not really contract effectively. As an example, as seen in this slide, idioventricular rhythm without a pulse is considered pulseless electrical activity. We are done with the arrest rhythms. We move on to less serious rhythm abnormalities. I will show you the slow rhythms now. A rhythm with a rate of less than 60 beats per minute is considered slow. A slow and regular rhythm with a normal PQRST sequence is called sinus bradycardia. Slow and regular rhythms with absent or abnormal looking P waves and with narrow QRS complexes is called junctional rhythm. In contrast with junctional rhythm, a slow rhythm with no P waves but with wide QRS complexes is called idioventricular rhythm. Slow regular complexes but with no definite PQRST sequence is a third-degree AV block or complete heart block. Slow with regular rhythms with no distinct P waves is AF, or atrial fibrillation with slow ventricular response. And slow irregular rhythms with P waves and abnormal PR intervals which exhibit group beating is second-degree AV block. Sinus bradycardia is a slow rhythm with regularly occurring PQRST complexes. The next few slides will define the different kinds of AV blocks. We begin with first-degree AV block. This is defined by a prolonged PR interval of more than 0.2 seconds or 5 small squares. Rhythm, however, still sinus and regular with a constant PQRST relationship. Type 1 second-degree AV block, also called Mobitz type 1 or Wenckebach, is characteristically an irregular rhythm with group beating. There is progressive prolongation of the PR interval until a P wave is no longer followed by a QRS. That missing QRS complex is called a drought beat. With QRS intermittently missing, the rhythm looks irregular. Type 2 second-degree AV block, also known as Mobitz type 2, also presents with an irregular rhythm with group beating. This is defined by the presence of a fixed PR interval but with the same dropped QRS complex. Second-degree AV block is distinguished from sinus pause by the presence of P waves with no subsequent or dropped QRS complexes. Complete heart block is shown. What you are seeing right now is a rhythm with regularly occurring QRS complexes. You also see P waves that are also regularly occurring. However, P waves are not correlated with the QRS. No definite relationship between the two can be established. And if you look closer, the R to R interval is not the same as the PP interval. The RR interval is longer, and the PP interval is shorter. All of this point to a complete dissociation between the atria and the ventricles. This is what you call a complete heart block. This ECG shows a 2:1 AV block. Not all P waves are followed by a QRS. One QRS complex appears only after two regularly occurring P waves. This next ECG shows high-grade AV block. In this tracing, 4 regularly occurring P waves are followed by one QRS complex. Any atrioventricular conduction with at least 3:1 ratio is considered a high-grade AV block. Junctional rhythm is a slow and regular rhythm with a rate typically between 40 and 60 beats per minute. P waves are absent or appear abnormal or retrogradely conducted. QRS complexes are narrow because the origin of this rhythm is in the area of the atrioventricular junction, as shown in the image on the right. Idioventricular rhythm is a slow and regular rhythm with a rate typically between 20 and 40 beats per minute. P waves are absent and QRS complexes are wide. This rhythm is typically encountered as an arrest rhythm, as we have seen earlier. The following is a special rhythm usually encountered in patients with artificial pacemakers. Notice the spike or blip preceding the QRS complex. This represents the microvolt stimulation of the device to generate cardiac contraction. The pacemaker system may be dual or single chamber, and the paced QRS complex is usually wide. The following cardiac monitors compare the dual chamber and single chamber systems with 2 pacing spikes or blips in dual chamber and 1 pacing blip in single chamber pacemaker systems. The following ECG shows regularly occurring PQRS complexes followed by a long pause. This is called a sinus pause. Sinus pause is distinguished from second-degree AV block by the absence of P waves and with no subsequent or dropped QRS complexes. We now move forward to fast rhythms. Rhythms with rates more than 100 beats per minute are considered fast and labeled as tachycardia. A fast rhythm with narrow and regularly occurring PQRST complexes is sinus tachycardia. A fast rhythm with no P waves but with narrow and regularly occurring complexes is called supraventricular tachycardia. A fast rhythm with P waves of varying morphologies and narrow and irregularly occurring QRS complexes is called multifocal atrial tachycardia. Atrial fibrillation is identified as an irregular rhythm with no discernible P waves. If AFib is running fast, it's called atrial fibrillation with fast ventricular response. A similar yet different rhythm to atrial fibrillation is atrial flutter. It has narrow QRS complexes and usually irregular, though at times it can be regular. This is easily identified with that sawtooth appearance, which actually are the flutter waves. Fast rhythms with wide regularly occurring QRS complexes is called ventricular tachycardia. Sinus tachycardia is a regular tachycardia more than 100 beats per minute. There is a normal PQRST sequence. Most often, this rhythm is encountered as a response to physiologic stress. Supraventricular tachycardia is a regular, narrow, complex tachycardia with P waves usually buried in the T wave or retrogradely conducted. The mechanism of this arrhythmia was shown in the earlier slides. Atrial flutter is a regular, narrow, complex tachycardia with characteristic sawtooth or flutter P waves. This rhythm may present with variable degrees of AV block, hence may present either as regular or irregular rhythm. The image on the right shows how electrical impulses travel in a circular pathway in typical counterclockwise atrial flutter. Atrial fibrillation is an irregular rhythm with no discernible P waves. The P waves are characteristically described as fibrillatory. The image on the right shows chaotic atrial signals originating from different locations on the right and left atria, producing irregular ventricular contractions. Ventricular tachycardia is a regular wide complex tachycardia. Occasionally P waves may be seen, but is usually dissociated since impulses originate from the ventricular myocardium and independent of sinus node depolarization. Torsade de Pointes is a unique rhythm which presents with fast, irregular wide complexes with typical twisted appearance, hence the name Torsade de Pointes. Usually this rhythm is seen on the background of a prolonged QT. Before you proceed to the next modules, remember these key points. Arrhythmia is easy. Remember the steps to ECG interpretation. Identify rhythms by looking at the PQRST morphology and their relationship, and categorize whether a tracing belongs to arrest, bradycardia, or tachycardia rhythms for the right management. Thank you for listening. You can now proceed to the module on cardiac arrest.